screen visible? Please do let me know. अभी तो शुरू भी नहीं किया, 2 डिसलाइक मार दिए बच्चों ने. I got it, sir.
Okay, sir.
Right, guys, am I audible and is the screen visible? Please do let me know. अच्छा लिख दिया किसी ने. Guys, am I audible? Is the screen visible? Can we start, please?
Sir, हो गया.
Okay, he's there.
चलो ओके सर, अब आप देख लो.
ये ब्लर ऐसे बच्चों को जा रहा होगा सर.
एक्चुअली क्या है, ये इस पे डिपेंड करता है. इसको फुल स्क्रीन होगा.
इसको फुल स्क्रीन वो मैंने किया था सर. ये जी ओके. सो हाउ डू आई नो बच्चों से बात करने वाला कहाँ पे है?
सर बात भी करनी तो मैं फिर आपको
मुझे लगा बीच में बच्चे का कोई क्वेरी हो. ओके हाँ, दैट्स फाइन सर, दैट्स फाइन. कोई क्वेरी हो तो मैं साथ बात करता रहूँ.
कि आ रहा है नहीं आ रहा, एवरीथिंग इज ऑडिबल.
Guys, am I audible? Screen clear? Is there any kind of blur, any kind of audio video lag you're experiencing? Please do let us know. प्रद्युत जी, अरे डॉक्टर पारस हैं ये तो. अनुग्रह जी, बड़ा नाइस नेम बड़ी. सर सर.
आप स्टार्ट कर लो, कोई दिक्कत नहीं.
ओके ओके.
बाकी बाद में देख सकते हैं.
Sir.
Idea they should be held by as much possible.
Sir, sir.
चलो सर, बेस्ट लक.
Right. Thank you, sir. Thank you so much, sir. Thank you. ये refresh करना. Yeah, now it's there. Good evening. Good evening. Good evening. Face scan small. Okay. We'll do it, but for today, let's finish the topic because we have to run according to the schedule. Rest of the topic of breast, we'll do it, don't worry. But as of now, we'll move according to today's plan. We move according to today's plan. Fine. So for today, we had a plan to cover the topic of hernia in a crisp and concise, clear, concise manner. Yeah, Arivrat ji. I know that some topic of the breast is still missing. Fine, we'll cover that. But as of now, please allow me to start the topic of hernia. Fine, we'll finish this. We'll inform you that whenever we are going to cover the topic of breast. Fine. Good evening. I'm so happy to be with you all. So I was also looking forward to meet you up. Fine. And I really want to meet the guys who dislike the videos. even before it started. Nevertheless. Okay. So what is hernia? So hernia is protrusion of viscera. Viscera means any abdominal organ or a part of viscera through an opening which is either natural or artificial. Protrusion of viscera to outside or any other body cavity fine, any other body cavity with a sac covering it, fine. So that means what we are looking for in hernia, first there should be protrusion of viscera, fine. Now second thing, there should be a sac covering it. Now speaking about the questions, there is a question. What is that question? That is, which hernia is there without a sac? Hernia which is there without a sac. Now let's say this is the skin, Fine. Let's say this is the skin. Okay. Now, just a minute. Okay. So after the skin, fine, there are muscles. There are different muscles. Fine. Different muscles. Fine. And then there is peritoneum. Then there is peritoneum. Right. Let me choose, just a second, please. Let me choose a different one note. This is not working good here. This is not working better here. I'm sorry. Now, I was going to tell you about the hernia, which is without a sac. Hernia, which is without a sac. Now, let's say these are the muscles. These are the muscles. Below the muscles, let's say, what is this blue colored thing? That is peritoneum. Now, what happens is that in the front of peritoneum lies pad of fat, lies a pad of fat. Now, what may happen is sometimes this pad of fat may herniate out. This pad of fat may herniate out and come to lie just under the skin, just under the skin. So this hernia is called epigastric hernia. So epigastric hernia is a hernia without a sac, is a hernia without a sac, the hernia without a sac. Yeah, gastroschisis is a special case. Gastroschisis is a special case. We'll read that. We'll read that. Fine. You don't worry. We'll read that. Now, let's say when I said a protrusion of viscera to outside or to any other body cavity, to any other body cavity. Now, let's say, what is this? Suppose this is chest, this is abdomen. Fine. Now, what is this? For example, there is a defect in the diaphragm. There is a defect in the diaphragm. Now, through this defect, intestine can move from abdomen into the chest. Intestine can move from abdomen into the chest. What is that? That is congenital diaphragmatic hernia. That is congenital diaphragmatic hernia. Congenital diaphragmatic hernia. Fine. Congenital diaphragmatic hernia. Now we have to read what exactly causes the hernia. What exactly causes the hernia? See, hernia could be congenital. It could be congenital. Fine. For example, the one which we just read, congenital diaphragmatic hernia. Fine. Or the hernia could be acquired. Hernia could be acquired. For example, in obesity, what happens is, now let's say, just a second. You see, let's say I'm close to 40 years now. So let's say these are your muscles. Your muscles. Fine. So your muscles, they are extremely strong. So there is minimal fat. Fine. And these would be my muscles. Fine. Not very strong and lots of fat in between. Lots and lots of fat in between. Fine. So wherever there is fat, that is considered the area of weakness. That is considered area of weakness. Thank you, buddy. Thank you, rockstar. You're actually a rock star. Fine. So that is the area of weakness. So that is what explains the presence of hernia in obese. Presence of hernia in the obese. Fine. Now, you see what else causes. For example, in pregnancy, there is increased intra-abdominal pressure. Fine. Trauma. For example, trauma, you have read, it can cause abdominal compartment syndrome. Fine. So there is increased pressure. What else can cause increased intra-abdominal pressure? What else can cause increased intra-abdominal pressure? Simple things like coughing, simple things like straining at the time of defecation, simple things like ascites, they increase the intra-abdominal pressure. They increase the intra-abdominal pressure. Fine. Now, for example, prostatism, that means there is bladder outlet obstruction. Patient has to apply great force while passing the urine. Fine. So that means that will lead to increased intra-abdominal pressure. So that will be the push factor. Yes. That will be the push factor. Fine. Push factor inside. For example, intra-abdominal pressure is very high, so it is pushing the abdominal contents out. It is trying to push the abdominal contents out like this. Trying to push the abdominal contents out like this. Now, this is happening. This is happening in anyone who has increased intra-abdominal pressure. But if there is coexistence of a weak abdominal wall, fine, your patient will definitely land up into this situation. Let me adjust my chair because I'm covering a large part of the screen probably. Let me check. Okay, so I've adjusted my position, so maybe I won't be covering too much. Just let me wait for a while. Let me adjust my chair. I believe now I'm not covering too much part of the screen. Or I still am. Can I just twist the camera a bit? Just give me a minute. Yeah, weightlifting. Basically anything which increases the intra-abdominal pressure. Karthik, but let's say your patient has had abdominal trauma. So abdominal trauma, what will be there in the abdominal trauma? Just give me a second. The video is not working probably. Just give me a second.
क्या हो रहा है सर?
Video stream. Yeah. Cam is not working, so we are trying. Just give me a second, please. Just wait. We are working on it. And also, this part needs to be made very small. I'm covering a large part of the screen.
Next video is the next bit.
Yeah. We know that the camera is not working. We are trying our best. We are changing it. Don't worry. Now the camera is working. We just need to make it small. This part needs to be small. It's covering large part of the PPT. Now I believe the camera is working. More small. मेरा PPT वाला part का sorry. इधर में अभी भी बड़ा अच्छा बाद में छोटा हो जाएगा राइट
50 कौन सा वाला ये वाली ना
हाँ जी मैं खोल के दूँ PPT this so that I'm not covering इसका बंद करके हम दोबारा खोलते हैं तो रिफ्रेश हो जाती है चाहे Okay. Right.
Now it's fine.
Okay. Sure. Can we make it more small? Because this part is covering. Because इधर वाला part जैसे मुझे दिखा
अभी देखो आप नहीं हो
अच्छा आप खड़े हैं तो आपके पीछे चुप रहा है ओके राइट थैंक यू हाँ ये ठीक है दिस इज ओके एग्जैक्टली विजिबल थैंक यू Right, guys, I'm really sorry. There was some delay. There was some trouble which we anticipated. I hope it's all working now. I hope it's all working now. Fine. So where were we? Yes. So increase intra-abdominal pressure, increase intra-abdominal pressure. Plus, if there is weakness, in the wall, fine. Now, you see here, the hernias, I told you they could be congenital. Now, we all know that the testes, they form in the abdomen. And later they descend to the scrotum. Fine. Now, when they descend to the scrotum, they descend through the deep inguinal ring. So you see, what happens is, let's say the testes, they are descending. Suppose they are descending. Now, when they are descending, what happens is that the deep inguinal ring opens up. Fine. As soon as the deep inguinal ring opens up, what happens is that the left testis, it moves down immediately into the scrotum. Now, as soon the testis moves down, the deep ring closes. Deep ring becomes very, very small. Fine. But right testis, it keeps on waiting whether I should be going or not, whether I should go or not. So what happens is, sensing the opportunity, what happens is, intestine says, testis, if you are not going, I am going. So what happens is that intestine moves out through the deep ring. Fine. So intestine will move out through the deep ring. So that explains why the congenital hernias, they are more common on the right side. So congenital hernia, they are more common on the right side. And I believe this question has been asked many a time. That why congenital hernias are more common on the right side. So this occurs due to later descent of right testis. This occurs due to later descent of right testis. Fine. Later descent of right testis. Now, second thing, let's say if your patient is a child, small child with a premature delivery. So especially if the birth weight is less than 1500 gram, that child is expected to have weak abdominal wall. Fine. Next, let's say your patient is having Marfan syndrome. Fine. Your patient is having any collagen defects. Fine. So that will also cause weak abdominal wall, and the intestine in that case can protrude out. Through the weak wall. Now, let's very quickly revise our anatomy. So we'll draw the skin layers, and we'll only draw the useful skin layers. Fine. The abdominal layer. So first layer is the skin. Fine. Then comes the fat. Fine. Now, abdominal layers we are speaking about. Then comes the external oblique. You all know from your knowledge of anatomy, that the lower part of external oblique is aponeurosis. Fine. Lower part is aponeurosis. That is more tendinous. Fine. Then next come the transverse abdominis muscle and the internal oblique muscle. Fine. So it would be internal oblique. Fine. And then comes the transverse abdominis muscle. Now, their lower part is also tendinous. And what do we call this? We call this as conjoint tendon, conjoint tendon. Now below this layer comes up the transversalis fascia, transversalis fascia, right? Now behind this layer is the peritoneum, fine. You all know from your knowledge of anatomy that there is a defect, there is a small defect in the external oblique. And what do we call this defect? This defect is called as superficial inguinal ring. Let's zoom it up. Fine. Let's zoom it up so that we can do it carefully. Fine. So this defect is called as superficial inguinal ring. Let's name this S. So this defect is superficial inguinal ring. Fine. You all know from your knowledge of anatomy that there is another defect. Fine. In the conjoint tendon. Let's call this as D. So what is that defect called as? Deep inguinal ring. Fine. Deep inguinal ring. Right. Now that defect extends in the transversalis fascia also, transversalis fascia. Now you see what will happen here. Because of the increased intra-abdominal pressure, the peritoneum will bulge out. Fine. Now here it will enter this zone, and ultimately it will come out like this. So this is hernia for you. Fine. Now you see this area which I have just shaded blue, what is this area called? This area is called as the inguinal canal. Fine. Now let me just show you some of the images and then we can continue with the topic of inguinal hernia. Now this is called as the mouth of the hernia. Fine. This is called as the body of the hernia. Fine. Now this region, the one which is very, very tight there, this is called as the neck of the hernia. Fine. So there is a hernia without neck. This is incisional hernia. So incisional hernia, usually they are very, very huge. They are very, very massive. Fine. So that is why we say that these are the hernia without a neck. Now you see, these are the components of the hernia. Now this is neck of the hernia. These are contents of the hernia. And the peritoneal layer which I just mentioned here. This peritoneal layer, this is called as sac of the hernia. Right. Now kindly allow me to move it like this. Now let's say, what is this structure? So let's say this structure is pubic tubercle. Now there is another structure here. What is this structure? Anterior superior iliac spine. Fine. You know that there is a ligament connecting this. What is the name of this ligament? This ligament is inguinal ligament. You also know from your knowledge of anatomy here that this ring we call as deep inguinal ring. Now there is another ring over here. We call this as superficial inguinal ring. Now what happens is, through these rings, the testes they come out. Body says that testis, you are extremely important to me. You are extremely important to me. So you please don't go alone while you are going down. Fine. Take a piece of peritoneum with you. Take a piece of peritoneum with you. Fine. These peritoneal folds, they help in the descent. They help in the descent of testis. Let me show you a small video here. Very small video. You don't have to worry. I mean, it's not going to be a long video there. Just have a look at the video. See here. So you see these red colored tubings which you see on your screen. These are the testes and their vas deferens which have come down. Testis and vas deferens which have come down. And this thing which you can see here, they are superficial inguinal ring. Superficial inguinal ring. Now you'll notice that how the peritoneal folds they come along. How the peritoneal folds they come along. See here. So along with the peritoneal folds, sometimes the intestine can also come along. Sometimes the intestine can also come along. Fine, you see the intestine coming out. Now you see, this can be strangulated. This can be strangulated at times. This can be strangulated at times. Fine. We'll return to this video later. We'll return to this video later. Fine, we'll return to this video later. Now you see. Now, so what happens to this? What happens to this? Let me just. Okay. So you see what will happen after this, that these two peritoneal folds, they will fuse with each other. These two peritoneal folds, they fuse with each other. They fuse with each other. Fine. And ultimately they are obliterated. They are obliterated. And what remains inside is testis. What remains inside is testis only. Fine. Now, you see here, sometimes what may happen is that they may remain open. They may remain open like this. They may remain open like this. Now, what might happen here is that the peritoneal fluid which is present may trickle along. Peritoneal fluid which may be present may trickle along. Fine. So, this is called as congenital hydrocele. This is called as congenital hydrocele. Now you see, this is abdomen and outside is scrotum. Outside is scrotum. So you see, there is a communication. There is a communication between abdomen and the scrotum. Abdomen and the scrotum. Fine. Now, sometimes what may happen is that just a second. Okay. Just give me a second. Sometimes what may happen is that these folds, they will close here. They will close here. Fine. They will close here. But the fluid which trickled from the abdomen may not get absorbed. Now you see, there is no communication between abdomen and the scrotum. Still there is hydrocele. Hydrocele means collection of fluid around the testis. Now this will be called as infantile hydrocele. This will be called as infantile hydrocele. How do you know the difference between the two? In examination, they will ask you that do you know the difference between infantile hydrocele and congenital hydrocele? You will say, yes, sir, I know. So that means in infantile hydrocele, there is no communication. There is no communication. There is no communication between abdomen and the scrotum. No communication. Peritoneum, Shashankji, will come out from the deep and then later it will come out of the superficial inguinal ring. Don't make any mistake. You see here, this is where the spermatic cord comes from. This is where the testis comes from. This is the deep inguinal ring. So peritoneum will first enter here, then it will turn here, then it will come out and then it will reach the scrotum. So this is superficial inguinal ring. This is superficial inguinal ring. Yes, Mutaya, you're right. Karthik, see, I hope I did solve your query. So this is your transversalis fascia and conjoint tendon. This is your external oblique muscle. I told you there is superficial inguinal ring over here. In the deep inguinal ring, in the transversalis fascia and conjoint tendon, there is a defect called deep inguinal ring. And you see this area is inguinal canal. So if the peritoneum is coming out, through along with the peritoneum, intestine can also come out. You see here. See, this is the transversalis fascia. And this is the spermatic cord coming out. Right? Now you see, this is again the inguinal canal. So this is deep inguinal ring. This is superficial inguinal ring. So peritoneum will come along with the testis. So this is testis. Fine. Along with testis, what did I tell you? That sometimes peritoneum can also come out. You see, if the opening is really small, fine, what will happen? Along with peritoneum, just some fluid will come. Fine. And that means your patient is having hydrocele. Fine. If the opening is really massive, fine, along with peritoneum, intestine can also come. Fine. That will be known as hernia. Fine. So this can be congenital as well as acquired. Right? Now, again, you see here, again in the same image, what did I tell you? Now, please, I know there are so many repetitions, but this repetition is important. Now, you see here, what is this? This is the spermatic cord coming out through the inguinal canal. Fine. And this is the testis. Fine. I told you along with it that peritoneal fold can come. Fine. Peritoneal fold can come. Now, if this opening, let me call this op. If this opening is small, only fluid can come. Fine. If this opening is small, only fluid can come. If this opening is large, intestine or any other intraperitoneal organ can also come. Any other intraperitoneal organ can also come. Intestine says, I want to go out. Somehow I want to leave the abdomen and go out. Fine. So there is another area. This triangle which I have shaded red as of now. Fine. This triangle is known as Hazel-back triangle. So this triangle, in this triangle, the abdominal wall is extremely weak. This triangle. Fine. So this triangle is called Hazel-back triangle. Let me show you more images here. You see here, this triangle. Let me draw this triangle for you over here. This. Fine. This triangle is called as Hazel-back triangle. So this area has very weak abdominal wall. So this is the Hazel-back triangle when you are sitting inside the abdomen. Now you see, just imagine yourself sitting inside the abdomen. sitting inside the abdomen, what is the first thing you will see? What is the first thing you will see when you are sitting inside the abdomen? This picture is more clear. What is the first thing you will see when you're sitting inside the abdomen? You will see transversalis fascia. You will see, yes, you will see the, what they call as the conjoint tendon, transverse abdominis muscle, fine. And this is the rectus abdominis muscle. This yellow shaded triangle is the Hazelback triangle. I told you this is a weak area. This is a weak area. So rectus abdominis muscle will form medial boundary. Inferior epigastric will form the lateral boundary, fine. And this reflected portion of the inguinal ligament that will form the inferior boundary. So intestine says that if I go out, this you see is the deep ring. Intestine says that if I follow the path of testis, I'll have to go like this. First, I will go to the deep inguinal ring. Then I will enter the inguinal canal. Somewhere here must be the superficial inguinal ring on the outside. Fine. Then I will get to go to the outside. Why shall I follow such a long route? Why shall I follow such a long route when I can go out from here directly? When I can go out from here directly. See, this is the deep inguinal ring. Somewhere here must be the superficial inguinal ring. Fine. So the intestine is coming out like this. Fine. Now, intestine says I can go out through the weak area, Hazelback triangle directly. Why should I not follow that route? Why should I not follow that route? Fine. So intestine says I will go out. When intestine comes out directly, see, in case of indirect hernia, what will be the route of intestine? Deep inguinal ring, superficial inguinal ring, then it will reach the scrotum. What will be the route of intestine? Abdominal wall, which is weak. Directly, it will land up into the scrotum. Now, what makes the abdominal wall weak? Appendicectomy. You know, in appendicectomy, what will happen? Appendicectomy, there will be injury to the ilioinguinal nerve that will make the abdominal wall very, very weak. Fine. So through this weak abdominal wall, intestine can come out directly. Intestine can come out directly. What else? What else make the abdominal wall weak? Age, you see. Elderly people, they have weak wall. Elderly people, they have weak wall. Fine. Elderly people, they have weak wall. Fine. So the direct inguinal hernia is common in elderly people. Direct inguinal hernia is common in elderly people, right? Because they have weak abdominal wall. Weak abdominal wall. Now you see, this is the neck of the hernia sac. This is the neck of direct hernia sac. So you see, this is very, very wide. So intestine, if it comes out through this route, intestine, if it comes out through this route, fine, it will not be compressed. It will not be compressed. While the intestine, which is coming out through this narrow, deep ring, has many chances of being compressed. Many chances of being compressed. Fine. Many chances of being compressed. So intestine will come out like this. Will come out like this. Fine. So those are the difference between direct inguinal hernia and indirect inguinal hernia. Indirect inguinal hernia. Fine. Very quickly, let me repeat at least some of this. Let me repeat at least some of this. Fine. You don't have to worry. It's not that no revision is too much revision. Fine. So this area is pubic tubercle. This area is anterior, superior iliac spine. This is deep inguinal ring. This is superficial inguinal ring. Now let me draw the rectus abdominis muscle. Fine. Rectus abdominis muscle. Fine. Now, this, let's say, is the testis. Fine. This is the peritoneum. Sorry. This is the peritoneum coming out. And let's say this time the peritoneum has intestine also. Let me choose a different color. This time the peritoneum has intestine inside. Peritoneum has intestine inside. Fine. So let's say this is intestine. This is intestine. Fine. So this, you see, is indirect inguinal hernia. While on the other side, let me draw this. On the other side, now let's say this is the deep inguinal ring. Let's say this is the superficial inguinal ring. And you see here, what I did was, these are the rectus abdominis muscle. Sometimes what may happen is intestine can come out through this area, I told you it is Hazelback's triangle, Intestine will come out directly. Fine, intestine will come out directly. Now, very quickly, let me compare. Now, you see here, this is the area through which direct hernia is occurring. This is the area through which indirect hernia is occurring. Now, you see, this is the midline. So, indirect hernia, you see, it is lateral to the inferior epigastric vessels. Direct hernia, you see, it is medial to the inferior epigastric vessels. Direct hernia, you see, is medial to the inferior epigastric vessels. Fine, inferior epigastric vessels. So what we have to do? We have to do Zeeman test here. These are the clinical investigations of hernia. Shashankji, in case of direct hernia, the obstruction can be there, but obstruction is very, very rare. Obstruction can be there, but obstruction is very, very rare. Suppose this is the intestine going out. Fine. Now, let's say this is the Hazelback triangle. Intestine is coming out. Now, abdominal wall is so weak that it cannot compress the intestine going out. So, obstruction or strangulation is very, very rare in direct inguinal hernia. It is extremely common in indirect inguinal hernia, but yes, this is very rare in the direct inguinal hernia. Now, this is a clinical test. This thing we will read after we read the topic of femoral hernia. Fine. Now, what? They say, what is the treatment? Fine. Now, you see, this is deep ring. We'll have to draw this diagram multiple times, so you please don't mind. Fine. Now, this is the pubic tubercle. Fine. Now, this, let's keep the testis secure and separate. Fine. Now, so let's say this is the peritoneum coming out. Fine. Now, what do we do? Over here? Fine. So, in children, what do we do is we do herniotomy. So, what do we do? The patch of peritoneum which came out along with the intestine, along with the omentum. What will we do? First, we'll send the intestine inside. We say, intestine, you have no business of staying here. You please go back into the abdomen. So you see, intestine is pushed back into the abdomen. Fine. Then what we do is, we will cut this like this. Fine. So, I knew this would happen. Just a second. So, we'll cut this. Fine. This thing can form again. So we will tie this. We will tie this. So herniotomy is when the intestine or other contents are pushed back into the abdomen, pushed back into the abdomen. Fine. The peritoneal fold is closed. Peritoneal fold is closed. Fine. Peritoneal fold is closed. This is herniotomy. This is herniotomy. This only is herniotomy. Fine. Now, this is done as surgical treatment in children. Mind you, there is no medical management of hernia. Hernia has to be treated surgically. Hernia has to be treated surgically. Now, we'll see what do we do. What do we do in case of adults? What do we do in case of adults? Fine. So, in case of adults, the problem is that most likely the deep ring is very, very wide. Let's draw this very wide for representation purpose. So deep ring is very, very wide. That is why, because the deep ring is wide, that is why the intestine came out. That is why the intestine came out. Again, the first step would be to push the intestine back. Push the intestine back. You see, first step, push intestine back. Fine. Now, second step would again be similar. Fine. That means we'll cut the extra peritoneal fold. So, second, peritoneal fold is cut. Now, this is herniotomy only. Fine. So, we cut it so that intestine cannot come out again. Now, you see here, problem is that this deep ring is very wide. Deep ring is very wide. Somehow, we have to close this deep ring. Somehow, we have to close this deep ring. Fine. So we can suture it like this. Fine. Once we suture it like this, the deep ring would appear somewhat like this. But consider this. Let's say this is the big opening. Okay, I'll show it here. Let's say this is the big opening. Now suppose you do it by yourself. Suppose what you do is with the other hand, you press it like this. That means when you make the deep ring tight, this is the deep ring. Suppose this is the deep ring. Fine. When you press it with other hand, you see, you will experience pain. You will experience discomfort. You will experience pain or you will experience discomfort. Same way, your patient will also experience pain. So the third step is tissue repair. That means wall of abdomen is made strong. Ring is made narrow. Now, this surgery which we perform in adults is herniorrhaphy. This surgery is called as herniorrhaphy. And this surgery we need to do in adults. There are different variants. For example, Bassini repair. Fine. There are Shouldes repair, Little's repair, fine, Little's repair, Marcy repair. So we don't use mesh, we don't use any foreign material, fine. That is why this is called a tissue repair only. tissue repair only. Sometimes what we do, let me show you some of the images there. We'll come to this, we'll come to the complications later. Fine. Let me just show you the surgeries there. You see here, Bassini repair. We are making the deep ring very tight. We are making the deep ring very tight. Fine. See, Bassini repair. We are making the deep ring very tight, so that next time the intestine cannot come out. No, 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 Shashankji. Herniotomy for children. Herniotomy for children. For adults, herniorrhaphy or hernioplasty. Fine, you see, this is Bassini operation. We just want to make the deep ring so tight that next time the intestine cannot come out. Next time the intestine cannot come out. This is how we perform. Now, the next surgery is Scholdes operation. Scholdes operation. So, in Scholdes operation, what do we do? Double breasting of transversalis fascia. So, in exam, if you see this word and inguinal hernia together, mark the answer as Scholdes repair. What is Scholdes repair? We do the double breasting. Transversalis fascia is like this. We say transversalis fascia do like this and like this. So now you see double strength is there. Double strength is there now. Fine. Double breasting of transversalis fascia. Now, you see, I told you that in any type of herniorrhaphy, because there will be too much pull. So there will be too much pain. What do we do is, what do exactly we do here? Fine. So just a second. Again, the same thing. Just give me a second. So this is very wide deep ring. Fine. Now the testis. Fine. This is the intestinal patch. What do we do is, we'll just cut it. We'll just cut it like this. Fine. Now, up to this step, the surgery is called herniotomy. Herniotomy. Now, to make this deep ring tight, we won't do anything. We'll leave it like this. But what we will do is, we'll apply a piece of mesh. We'll apply a piece of mesh. We'll apply a piece of mesh over this. Fine. We'll apply a piece of mesh over this. If we apply a piece of mesh, fine. Now the surgery is called hernioplasty. What is the name? The name is Lichtenstein repair. Lichtenstein repair. Thank you, buddy. So hernioplasty is when we use a mesh. When we use a mesh. Fine. When we use a mesh, that is hernioplasty. What is the name? Lichtenstein repair. Lichtenstein repair. So main benefit of Lichtenstein repair is no pain. No pain at all. Now, what are the questions which we expect? So very quickly, hernia surgery for children. Herniotomy. Hernia surgery for adults. Herniorrhaphy, hernioplasty. Fine. Now, what is considered the gold standard open repair, if you want to call it, that is Lichtenstein repair. Fine. Now, the next thing is most common nerve injured. Most common nerve injured during hernia surgery. Fine. So this is ilioinguinal nerve. Most common nerve which is trapped. Most common nerve which is trapped below the mesh. That is iliohypogastric nerve, iliohypogastric nerve, iliohypogastric nerve. Fine. Sometimes we may have to do laparoscopic surgery. Laparoscopic surgery. Fine. What is laparoscopic surgery? So there are two methods, TAPP and TAP. Transabdominal preperitoneal, total extra peritoneal. This is not important, I mean remembering the names, but let's see what do we do here. What do we do here? Suppose you are sitting inside the abdomen. Suppose you are sitting inside the abdomen. So what did you do? First you cut the peritoneum. When you cut the peritoneum, abdominal muscles are now visible in front of you. Abdominal muscles are now visible in front of you. So also visible are the criminals, deep inguinal ring through which indirect hernia can occur. Fine. I'm really sorry. There's no investigation of choice. Hernia has to be a clinical diagnosis, but if you want, you can diagnose it with the help of ultrasound. You can diagnose it with the help of CT scan. Fine. There's no investigation of choice there. Fine. Now, you deep inguinal ring. You know that indirect inguinal hernia can occur from here. Then you know that this area is Hazelback triangle. This area is Hazelback triangle. Fine. Now, you know that through these all areas the hernia can occur. You know that this is saphenous opening. Through this femoral hernia can occur. Through this femoral hernia can occur. So what do you want to do over here is you want to apply a big mesh. You want to apply a big mesh that will cover everything. That will cover everything. Fine. Now, that will cover every hole so that there is no future hernias also, like an insurance policy. Now, after you have applied the mesh, what do you need to do? You need to secure it. You need to secure it with the help of mesh, with the help of tack. So, suppose you apply a tack over here, very good. Suppose you apply a tack over here, very good. But by mistake, if you apply a tack over here, the tack, you know, tack, what are tack? Tacks, they are like drawing pins, which we used to use in school. Fine. So, this tack, the drawing pin, will enter the iliac vessels, and your patient may die. Your patient may die. That is why this is called as triangle of doom. That is why this is called as triangle of doom. Fine. So, if you apply a tack over here, there could be problem. You are scared. You say, no, I won't apply tack over here. So you move laterally. What do? You apply tack over here. Now what happens? You apply tack into the nerves. You apply tack into the nerves. You can see there are so many nerves around. So you say, okay, enough of it. I am not going to apply a tack in the triangle of doom. I'm not going to apply a tack in the triangle of pain. Fine. Just a second. There seems to be some. Just give me a second. I believe everything is all right. So there was some disturbance on the outside. I just wanted to check if everything is all right. Karthik ji, mesh is usually made up of prolane. I'll tell you about the mesh. Don't worry. I'm here to tell you everything, but I'm glad you people are asking questions. Fine. Now you say the surgeon feels if I apply tack in this region, artery can bleed, patient can die. If I apply tack in this region, veins can bleed. So why not I move medially? Why not I move medially in this region? Fine. Surgeon moves, but when it is not your day, it is actually not your day. Fine. So what happens is in this area, sometimes what may be present is an aberrant obturator artery. Aberrant obturator artery. Fine. This aberrant obturator artery makes us to name this area as corona mortis. That is called as the crown of death. Crown of death means death is everywhere. Death is everywhere. Fine. Death can catch us anywhere. Fine. So you see, why I'm saying that death can catch us anywhere? Because you see, this area medial side, we considered that this area is extremely safe. Apply tack here. But sometimes there can be an aberrant obturator artery. Can you see here? This aberrant obturator artery. Fine. So if you apply tack over here, this artery can bleed and patient can die. Patient can die. So you see, what is the best thing to do in this case? Best thing to do in this case is that apply tack in this region only, which I have shaded red, and don't apply tack in this region which I have shaded blue. So apply tack above the iliac crest. Tack. Why do we need to apply tack? Because we want to fix the mesh. We want to fix the mesh. Fine. So during laparoscopic surgery, bleeding may occur in the triangle of doom, which is lying in the medial location. Fine. Nerve injury can occur in the triangle of pain, which is lying laterally, and which is the most common nerve to get injured. Most common nerve to get injured in the laparoscopic surgery is lateral cutaneous nerve. Lateral cutaneous nerve. Lateral cutaneous nerve. Fine. And more medially, where near Cooper ligament, lies corona mortis, that is the crown of death. And what is present there? Aberrant obturator artery. Aberrant obturator artery. Fine. So this question has been asked many a times, which is the most commonly injured nerve during laparoscopic surgery. Most commonly injured nerve during laparoscopic surgery. Now, your doubt. So what kind of mesh? Mesh are usually made up of polypropylene. Sometimes they may be made up of a mixture that is proline, fine, and vicryl. Remember what is vicryl? Polygalactin. So these are lightweight meshes, comparatively lightweight meshes. Fine, lightweight mesh, right? Now, we'll study what are the different complications which we can encounter in hernia. What are the different complications which we can encounter in hernia? You see, hernia sometimes can become irreducible, sometimes it can become even more severe, that is, sometimes it can become obstructed. We'll see all of them. Fine. Just give me a minute. The PPT needs a bit of shuffling actually, because I adjusted according to the concise class. Now, you see here, this is the defect through which the hernia came out. Please be ready with your doubts. I will be much more than just happy to solve all your doubts. Fine. You see, the intestine comes out. Fine. Now, if you push it, intestine can go back inside. So that means it is reducible hernia. Sometimes what happens is intestine develops vascular connections here. Now, this will be called as irreducible hernia. Now, sometimes what may happen is you see here the lumen is contracted. So, what is this? Obstructed hernia, obstructed hernia. Sometimes its blood supply may be cut. At that time, what do we call it? Strangulated hernia, strangulated hernia. Jawaharji, crown of death is when you apply the tack medially thinking that there will be no important structure over here. By mistake, you find that there is an aberrant obturator artery. You applied the tack thinking that nothing is there and the artery started bleeding like hell. Patient may die. Fine. That is called crown of death. Now, you see here. So, this is tight hernia sac causing incarceration. Incarceration means there is obstruction of the lumen. Now, then what may happen? There might be obstruction of the blood supply. Now, you see here. When there is obstruction of the blood supply, what kind of bacteria appear? Anaerobic bacteria. Now, this is peritoneum. Peritoneum can absorb the things very, very quickly. It can absorb the toxins immediately. So, your patient will suddenly become very, very sick. Fine. Suddenly, your patient will become very, very sick. So, that is strangulated hernia. Why your patient will become very sick? Because the strangulated hernia is badly infected, Fine. Now, what is the treatment of strangulated hernia? Because your patient is sick, give your patient IV fluids, give your patient antibiotics, and most important, immediate surgery. What kind of question do they ask? So, in the treatment of strangulated hernia, no mesh, they will ask you, what is the treatment of choice in strangulated hernia in adults? Fine. So, the treatment of choice will be herniorrhaphy. And which procedure? Bassinis operation. Now, we are going to see some special case. So, Richter hernia. So, Richter hernia is a special case, that is strangulation without obstruction. You see, because only this part which I have shaded yellow will develop strangulation. So, there will be no obstruction at all because the lumen is not blocked, as you can see on the screen. Only the area which I have shaded blue, that will develop strangulation. See here. So, this area will develop strangulation while the lumen is running continuously. There is no obstruction. Fine. So, Richter hernia. What is Richter hernia? Richter hernia is strangulation without obstruction. Fine. Strangulation without obstruction. What is midal hernia? Midal hernia is also called as hernia NW. So, you see here, rather than single, there are double loops of intestine. Fine. Now, the strangulated loop lies deep inside the abdomen. See here, strangulated loop lies deep inside the abdomen. Midal hernia. Shashank, good question. First of all, your question is too good. What kind of question will be asked? The question will be that there is a patient presenting to surgery OPD with high-grade fever. With obstipation, that means patient is not passing stools. When you examine your patient, a tender means painful, a tender lump is noted in the inguinal region. Patient is not passing flatus. Patient is not passing stool. Patient is vomiting. Abdomen is distended and there is a tender lump. Strangulation is the diagnosis, especially if the patient has fever. They might also mention that there is increased total leukocyte count, toxemia. So there will be features of toxemia. They might ask you what is the treatment. Immediate surgery. Immediate surgery is the treatment. Immediate surgery in the treatment. This question has been the favorite of examiners in the viva, not in the MCQs. Fine. They say if the intestine is coming out, what is that called? Enterocele. Fine. If the omentum is coming out, we prefer to call it omentocele. Omentocele. Fine. Don't remember this epiploicele. Fine. So in enterocele, I told you we're going to send the intestine back inside. First part is difficult to reduce, but in the case of omentum, it is the last part which is difficult to reduce. First part, last part, difficult. Fine. Remember this. In intestine, it is the first part which is difficult to reduce. In omentum, it is the last part which is difficult to reduce. Right. Now, they're going to ask you how can you differentiate between the hernia and hydrocele? Hernia and hydrocele. Now, let me just tell you about the hydrocele. Now, let's forget about the abdomen. We are discussing this in adults. You see, testes, they have two layers, tunica albuginea and the outer layer, that is tunica vaginalis. Sometimes what may happen is fluid may accumulate between the two layers. Fine. So this is adult onset hydrocele. Mind you, we are not talking about the congenital hydrocele. We are talking about adult onset hydrocele. Fine. Now, if you see this like this, fine, this swelling will be brilliantly translucent. I mean, the light will easily pass through this. The question usually comes, what are other translucent swelling? Meningocele, cystic hygroma. We have time. Cystic hygroma, right? See, this is testis and the covering is tunica vaginalis, the outer covering. Fine. Same time you may get another patient. Fine. Now, this patient is having hernia. So what are they? They are the peritoneal folds. Fine. Now, these peritoneal folds, they might have intestine inside. Fine. Now, you see, you can easily reach on the top of hydrocele. So we can reach above the swelling. You can easily touch the top of the swelling. Here in the hernia, we cannot reach the top of swelling because top of swelling is somewhere inside the abdomen. Fine. This swelling is not reducible. This swelling is reducible. Fine. So that is how we differentiate hernia from hydrocele. Now we have some of the named hernias. Fine. So named hernias, for example, Amai and hernia. Amai and hernia is the hernia which has appendix. Fine. We have Little's hernia. If the hernia has Meckel's diverticulum. Fine. We have Pantaloon hernia. That means both direct and indirect hernia. We have Gibbon hernia. Gibbon hernia means hernia with hydrocele, hernia with hydrocele, Gibbon hernia, hernia with hydrocele. Fine. Now, wait. Now, this thing, a new concept, probably the examiners are, not very inclined to us. So, if we add triangle of pain and triangle of doom, that is called as trapezoid of disaster. That is called as trapezoid of disaster. Trapezoid of disaster. Find trapezoid of disaster. Now, this is special type, last type of inguinal hernia, last 1 minute of inguinal hernia. I know we are reading too much of inguinal hernia. Now, sometimes not only, see this where I have written intra, that is intra peritoneal. Sometimes what may happen is some extra peritoneal organ they can also accompany. Some extra peritoneal organs they can also accompany. What is that? Hernia englisade, for example, urinary bladder, for example, sigmoid colon. They can also accompany. Fine. And they might get damaged. For example, you give incision here in the skin, and your incision can extend deep into the sigmoid. Image based question. What is this? This is truss, tight underwear kind of thing, by which you press the hernia inside. Now, hernia truss is not useful for this hernia, sliding hernia, also called as hernia englisade. Hashim ji, for the treatment of hydrocele, we have 2-3 approaches: Lord plication or jabuloplasty. Fine. So we don't have to open the abdomen. We just give a nick over the scrotum and then we perform the surgery. Now, femoral hernia, you see, femoral hernia is through the saphenous opening. Intestine is desperate to go out. Intestine say, I want to leave the abdomen, I will leave. Now you see here, can you see this pouch of peritoneum? Intestine says that iliac vessels are going from abdomen to the leg. So I will also travel along. Fine. So you see intestine traveling into the leg or lower limb. Femoral hernia. See, intestine traveling from the abdomen into the lower limb. Fine. So this is pubic tubercle. This hernia will be found below and lateral to pubic tubercle. Now allow me to draw this. You see here. Fine. This is pubic tubercle. You see, femoral hernia is below and lateral to pubic tubercle, while the inguinal hernia is above and medial to pubic tubercle. Fine. Check. Okay. Let me write here. So, femoral hernia, F for femoral. Fine. So, femoral hernia is more common in females. Which female? Middle-aged females. Fine. So, this hernia lies below and lateral to pubic tubercle. Fine. Now, it has high chances of strangulation. Fine. Make no mistake, femoral hernia is more common in females, but most common groin hernia in females is indirect inguinal hernia. Direct inguinal hernia is not commonly seen in females. Practically, it is not seen in females. Fine. Now, Femoral hernia. So you see, half of the hernia is present in abdomen, half of the hernia is present in lower limb. Fine. So if we open the abdomen, that is called as higher approach or inguinal approach. We do it only when there is complicated hernia present. Complicated means strangulation has already developed. So low approach is used. Low approach will be using when there is no complication seen. What is the name of surgery? Lockwood operation. Lockwood operation. Femoral hernia. Femoral hernia. Fine. So the only thing which you need to notice it that this is the opening. What is the name of this opening? Saphenous opening. The hernia is below and lateral to the pubic tubercle. Fine. It is more common in female. It has higher chances of strangulation. Higher chances of strangulation. Fine. Now, the umbilical hernia. Someone of you asked me today morning, at least two of you sent me a question that what is umbilical hernia, what is para-umbilical hernia. See, umbilical hernia, what will be there? There will be eversion. There will be eversion. That means umbilicus itself will come out. Itself will come out like this. You see, this is the skin, intestine. It will come out of the abdomen. Umbilicus will be everted. See, normally the umbilicus is like this. Fine. Like this, gone inside. What will happen in the hernia? That umbilicus will be totally everted. It will come out. Fine. Like you can see in this image. Fine. You can see in this image. I want to show you something else here. See. Now, sometimes there would be para-umbilical hernia. Para-umbilical, that means around the umbilicus. Fine. So there, whenever you get to see crescent-shaped umbilicus, Avinash ji, Lockwood operation is the treatment of femoral hernia. So whenever you see the crescent-shaped umbilicus, this would be para-umbilical hernia. Para-umbilical hernia. Para-umbilical hernia. See, again you can see crescent-shaped umbilicus. Crescent-shaped umbilicus. So, only part of the umbilicus is protruding. At least two of you sent me this question. So, that's why I'm mentioning it. Fine. The difference between umbilical and para-umbilical. Difference between umbilical and para-umbilical. Now, you see here, umbilical hernia, if there is present in adults, so we do surgery as early as possible. Why? Because there are chances of strangulation. We're about to finish, don't worry. Fine. There are chances of strangulation. Fine. Umbilical hernia, if it is present in children, what do we do in that case? Fine. Umbilical hernia, if it is present in children, we wait and watch for at least 2 years. We wait and watch for at least 2 years. We do the surgery if the defect is more than 2 centimeter, if the defect is progressively enlarging, in that case we will do surgery. Otherwise we'll prefer to wait. Fine. In para-umbilical hernia also we do surgery as early as possible. Now, what do? We place a mesh. Fine. Now, we place a mesh. One is we can do suturing. Fine. Fine. The suturing is done if the defect is small, but the preferred approach is to place a mesh. Fine. If we place the mesh posterior to the muscle, that is called as onlay mesh. If we place the mesh in between the muscle, that is called inlay mesh. If we place the mesh behind the muscles, that is called as sublay mesh. If we place the mesh inside the peritoneum, that is laparoscopically, that is called IPOM. Intraperitoneal onlay mesh. You see here, anterior to the muscle, in between the muscle, posterior to the muscle, and inside the peritoneum. See another layer. Fine. You see onlay, sublay. Fine. And then we have preperitoneal, intraperitoneal only mesh. Yes, anywhere around 2 centimeter. Good. Now, you see, we have to differentiate here between two things, gastroschisis and omphalocele. So in gastroschisis, we do immediate surgery because you see here, in omphalocele, the intestine which is protruding out is covered by a layer of peritoneum. But in gastroschisis, it is not covered by any layer. So it may desiccate immediately. Fine. You see, omphalocele, O is closed from all sides. G is open from here. So the intestine is protruding out without any covering. Fine, like this. Fine. So we will do immediate surgery. Fine. Now, just a second. I forgot to add this one image here. Yes, this. So you see, what do is, we don't send the intestine inside in one go. First we cover it up. Fine. Then we keep on pushing it part by part. If we push everything inside in one go, abdomen is so tight, we may not be able to close it. So silo approach can be used for gastroschisis. Yes, Dr. Level Up. It should always be surgery. In paraumbilical hernia. Now, Pigelion hernia. Pigelial hernia is intraparietal hernia. Fine. You see, hernia may not be detected for long because it lies in between the 2-3 muscle layers. Pigelion hernia. Fine. Now, not very important there. Obturator hernia is called as old lady hernia. This is common in elderly, frail females. Now, this occurs through the obturator foramen. See here. Occurs through the obturator foramen. Fine. Obturator foramen. Right? Obturator foramen. Now, lumbar hernia. So you just need to remember the name. Inferior lumbar triangle, that is a triangle of Petit, and superior lumbar triangle, that is a triangle of Greinfeld. That is the only thing which you need to remember. Internal hernias are not important here as of now. Fine. Now, please send your queries. Yes, okay. Mesh in case of umbilical hernia. Very good question. Extremely good question. I really like this question. Now, suppose this is a defect. Now, This is the muscle layer. What do we do? That let's first of all, we enter this laparoscopically. We enter the abdomen, and then what we do is we bring the intestine back inside. We say, intestine, you have no role. Going out. Fine. Now what we do? Here in this area, we will apply a mesh. Fine. What is that mesh called? That mesh is called composite mesh. I'll tell you what is special there in composite mesh. You see, here we will apply a mesh like this. Fine. Composites. Double layer mesh. Fine. Inner part will be made up of proline. This part will be made up of polytetrafluoroethylene, so that it does not adhere to intestine. It does not adhere through intestine. Fine. It does not adhere to intestine. Thank you so much, buddy. Doctor, level up. You're actually one level up. And I really like that. See, buddy. So suppose you are sitting inside the abdomen. First thing you will notice is the peritoneum. You cut the peritoneum. Now what you notice is abdominal wall. Now this area is the space of Rectus. Pre-vesicle. That means in front of the bladder. If you come more laterally, this is the space of Bogros. So pre-peritoneal space. That means space in front of the peritoneum. Truss, Mithila. Beta ji, truss is used as a temporary stopgap measure. If the patient says, I don't want to get the surgery done, you say that only treatment is surgery, no other treatment at all. If the patient still does not agree, you say, okay, wear a truss. If for medical reason you are not able to do the surgery, fine. In that case, you will use truss. Sufia Sheikh, beta, omphalocele is intestine coming out. Omphalocele is a congenital condition. Intestine is coming out and it is covered by a layer of peritoneum. You just send it inside and close the abdomen layer. But for intestine, omphalocele, you can wait for 1 to 3 days. But gastroschisis is a surgical emergency. It needs to be corrected immediately. Strangulation, Kavita. Yes, beta, no problem. You see here. So, okay. So let's say intestine is coming out. Like this. Now, intestine is coming out. Sometimes what may happen is that this area can become so bad, this area can become so tight that this blood supply may be totally gone. Now let me just start that video again for 10 seconds only. I'll just play it for 10 seconds. Kavita beta, see this. Shashankji, wait. Ladies first, na? Now Kavita has asked a question. Kavita beta, see. Hernia sac. Intestine coming out through the hernia sac. Sometimes too much of intestine can come out. Fine. Now that intestine can be compressed by the superficial inguinal ring, which you can see at the moment on the screen. So you see intestine is compressed. Dam ghut jana, gala ghut jana. Tap and tap. Tap is transabdominal preperitoneal. You want to place a mesh in the front of peritoneum. One way is you can go inside the abdomen, cut the peritoneum and place a mesh. You are going inside the abdomen, which is not a good thing. So other thing is what you can see on the screen right now. You don't go inside the abdomen. You just go behind the abdominal muscles. Don't cut the peritoneum. That is total extraperitoneal. Now this is when you are inside the abdomen. See, this is on the screen. You can see when you are inside the abdomen, you pull the intestine back. You see, you are pulling the intestine back. Intestine which is covered by peritoneum. You are pulling it back. You are pulling it back. See, you are pulling it back. Now the deep ring is clearly visible. Here you will apply a mesh. Here you will apply a mesh. That is what you do in the laparoscopic surgery. Vijay Pradeep ji, disc hernia is a topic of orthopedics. Prolapse intervertebral disc. Prolapse intervertebral disc. You need to remember only two things: Lesage test, straight leg raising test. Fine. And the treatment. Microdiscectomy is the treatment of choice there. Microdiscectomy is the treatment of choice. Also, you can remember the 4 stages: degeneration, prolapse, fine, and then there would be extrusion, and last would be sequestration. Treatment of choice for femoral hernia is immediate surgery. If there is complication, you go in for a high inguinal approach. Fine. If there is, you can go in for a high inguinal approach, that is called as Henry's operation. Henry's operation. If there is no complication, you can go in for low inguinal approach, that is Lockwood operation. Sir, what will we do for omentocele? Same treatment. Beta, omentocele, Nitin V. Beta, what is omentocele? Omentocele is hernia only with intestine as its contents. Oh, sorry. Omentocele is the, I'm really sorry. Omentocele is hernia only with omentum as its content. See, omentum can also get strangulated. So we will push it back. We'll push it back. Dr. Katir, for children, see, if there is hernia, the only treatment is surgical. Surgery has to be done. For children, treatment is herniotomy. Fine. No repair. Just send the intestine inside. Just cut the peritoneal cover. Fine. Which came outside. Herniotomy. If you tighten up the abdominal wall, that is herniorrhaphy. If you don't tighten but cover the defect in the abdominal wall with a mesh, that is hernioplasty. So you do herniorrhaphy and hernioplasty in adults, while you just do herniotomy in children. Herniorrhaphy, named surgeries, Bassini operation, Scholde's operation. At least remember these two. Oh, I'm here, sorry. At least remember these two. Fine. Hernioplasty, named surgery is Lichtenstein operation. Lichtenstein operation, that is mesh plasty or mesh hernioplasty. The question, which is the most commonly damaged nerve, ilioinguinal nerve, most common nerve, which is trapped below the nerve, or which is trapped below the mesh, iliohypogastric nerve. Complication of umbilical hernia surgery, you give an incision in the skin. It might cut the intestine immediately. Complication ही complication, जितनी मर्जी ले लो. No specific complication. Mesh material could be, polypropylene, proline, and you could also use Vicryl. Fine, both in combination, not alone, in combination. For mesh, you should always use a material which is non-absorbable. But if you want to make the mesh light, you could remove some of the polypropylene and then you can again add some of the Vicryl in its place. So two type of meshes. One is polypropylene only. Second is polypropylene plus polygalactin. What is polygalactin? Vicryl. If you are using intraperitoneal, then you will be using PTFE, polytetrafluoroethylene. Femoral hernia anatomic positioning will be below and lateral to the pubic tubercle. Below and lateral to the pubic tubercle. Let me show you here. See, below and lateral to the pubic tubercle. Below and lateral to the pubic tubercle. Magendra ji, yes, I do have time, but I believe that we should do it with prior announcement. We should do it with prior announcement. I am here for you all the time. I'm not going anywhere. Fine. I'm there with you all the time. Till the time you clear your exam, we are there by your side. We are there by your side. Please don't worry about anything. Just focus on your studies. Leave everything to us. Yes. So, summarizing, this is the deep ring. Somewhere here lies the superficial inguinal ring. So, intestine will come out like this. First, it will enter the deep ring. Then it will enter the superficial inguinal ring. Then it will come out. While here, it will come out directly. This is, weak abdominal wall. You can call this weak abdominal wall. You can call this weak abdominal wall like this. Weak abdominal wall. It is coming out directly. It can come out if the wall is weak. And who have weak wall? Aged people. Fine. So direct hernia is more common in aged people. It comes out through Hasselbalch's triangle. Remember, the indirect inguinal hernia is coming out through inguinal canal. Fine. It will be elliptical. See, elliptical like this. Fine. It is globular, round, globular, that is round. Fine. That's it, I believe. Oh, sorry. I'm really sorry. This is the most important. Indirect hernia will be lateral to inferior epigastric artery, while the direct hernia will be medial. Very good question. Level up, my dear. You're asking extremely good questions. Now, you see, indirect inguinal hernia is coming out through deep ring. Fine. Direct inguinal hernia is coming out through Hasselbalch triangle. Femoral hernia is coming through saphenous triangle. What do? We ask the patient to lie down. When the patient lies down, the abdominal pressure is reduced. Hernias go inside. Then, with these three fingers, what do? We close the deep ring so that indirect hernia cannot come out. Keep on listening to me. We close the deep ring so that indirect hernia cannot come out. We close the superficial inguinal ring so that direct inguinal hernia cannot come out. We close the superficial, we close the saphenous opening so that femoral hernia cannot come out. Now we ask the patient to cuff. Fine. Whatever finger will be vibrating the most, if this finger over the deep ring is vibrating, your patient has indirect inguinal hernia. If the middle finger which you placed over superficial ring is vibrating, your patient has direct inguinal hernia. If the index finger you placed over saphenous opening is vibrating, is shaking, that means your patient has femoral hernia. This test is called Zeeman test or three finger test. Another test I have. You ask the patient to lie down. Now what you do is you just close the deep ring. Don't do anything else. Just close the deep ring. If the hernia is still protruding, then it would be direct inguinal hernia. Because the direct inguinal hernia does not come out through the deep inguinal ring. Dr. Dante Han, You did erase some query. Please don't do that, buddy. Whether it is a query, whether it is a criticism, I like all. Surgery is always interesting, buddy. Surgery is always interesting. Yes, Shashank ji, I told you about this hernia called pantaloon hernia. Direct and inguinal Dowd operation is the operation which you use for this lumbar hernia. Avinash ji, I did answer this question on Zeeman test. Yes, I'll request Dr. Paras sir and he'll do the needful, don't worry. Okay, Dr. Dantehan. Right. Shashank ji, definitely, it's enough. Try solving the MCQs. If you don't find any, I'm always there for you. Can we end the class right now? Right, it's time for me to go back home. I don't know how to end the class, so I'll request sir. हाँ